Hello and welcome to another in Stockton's series of Brown Bag Advising Colloquia. Today we welcome Dr. Christine Gayda-Chelder, Assistant Professor of Psychology at Stockton University. She's also a licensed clinical psychologist with a subspecialty in neuropsychology. She'll be speaking today on unique issues in advising the student with post-concussive syndrome. So we welcome Dr. Chelder today. Thank you.
Thank you very much. I want to first acknowledge Dr. Mark J. Chelder, who really brought about the idea for this. I was at an ACADA conference a couple of years ago with the academic advising team, and Dr. Mark Chelder was with me. Yes, I'm related to him. And he noticed that there didn't seem to be a lot of literature about advising the student post-concussion. So I have to thank him for his really pushed to get this presentation and paper together that is being written. Gabriela Navarro is one of our graduates right now applying to graduate school. She graduated last spring and she has contributed greatly. And very important that you know my background. I always say to my students, you pay a lot of money to listen to me. What gives me the right to tell you what I'm telling you? What is my background? So my undergraduate work was at Marywood University in Scranton, PA, and it was Dr. Raymond Martinetti who taught me physiological psychology and developed my passion for the brain, and the impetus to volunteer at a neuromed unit where individuals were living who had a very severe brain injury, people, most of them in a persistent vegetative state. I started that work when I was about 20 and then decided to specialize in neuropsychology. And Dr. Frank Mercala was very instrumental as well. And I feel the need to mention this because those of you out there who are advisors, you are mentors, you help weave who all the students become. We have mentors. Never forget, faculty, we had mentors who have inspired us. So being a part of an academic advising brown bag, I think it's so important to mention this. And I have the future of neuropsychology here with me today. 5 students from my clinical neuropsych classes this semester who will be helping. I want to thank them. And also Doris, who works with Dr. John White, who helped today with some editing of my talk. She is wonderful. So first and foremost, we're talking about concussion. And I want you to remember that the New Jersey Brain Injury Association years ago had a billboard. Bones heal, brains don't. You've got about 100 billion neurons, specialized nerve cells in your brain. You've got 4 lobes we'll go over briefly, and many, many other structures. I could talk for years about the brain. Yes, you may have heard of neurogenesis and rehabilitation. People can get better from a brain injury, but once you have severe, permanent loss of neurons, they don't come back. We're learning more about how that might happen. But for right now, please know, your brain can improve to a point. And that's what's critical. That's why we have to have children wear bicycle helmets. Real quick, parts of the human brain, there are, again, so many. But I like to quickly talk about the 4 main lobes in the hindbrain. The cerebellum, which you see at the bottom, controls your balance, movement, coordination. Occipital lobes, visual processing. Parietal lobe, sensory processing. Temporal lobe, memory. Your frontal lobe is the seat of executive control. Helps hold back impulses. Frontal lobes are often really the lobes that are most injured in a brain injury. They're right here behind your forehead. Imagine this. Here's your skull. Here's your frontal lobe. You're doing 100 on the Garden State Parkway, and all of a sudden you realize, oh boy, I better stop. Your brain is going to pound. Thank you, Anthony. Anthony is nodding. He knows. He works in healthcare. Your brain is pounding on the skull. Contusions, bruising. And this is what makes us distinctly human. Initiation, planning. Remember that. It's going to come up again with concussion. Your frontal lobes help you focus, hold back impulses, that impulse to yell at your professor, students. Hopefully your frontal lobes work well and you hold back. These are all incredibly important areas of your brain. And again, I hate to rush through this and not give the brain its due, but it is just amazing. And many of you may know this. It controls everything: heart rate, respiration in the medulla oblongata, your attention, your expressive language, your understanding of language, executive control, which I mentioned, which includes problem solving, impulse control. My students in neuropsych just covered the fascinating topic of memory, and they took a memory test, a very challenging one. Memory is complex. You must attend, encode, learn, be able to get it out, and there's verbal and visual memory. How many of you know which side of the brain mediates more verbal memory, like remembering words and prose passages? Who knows which side of the brain is more verbal functioning, language? Anyone know? My students just learned this the other day. Left, correct. Right is more visual, visuospatial, so we assess visual memory. We have people learn and remember faces, designs. Verbal memory is more word lists, prose passages, things like that. Sensory motor functioning. Right side of the brain controls left side of the body. Left side of the brain controls right side of the body. So if you have a stroke, let's say, in the left side of your brain, your right side may be weak. Emotional functioning, personality is controlled by the brain, drives for hunger, thirst, and sex. Dr. John White is here today, who does amazing work with those who are sex offenders. He's writing a textbook, The Neuropsychology of Sex Crimes, correct? Violent crimes. Something like that. This is cutting-edge information we now have about how the brain affects those behaviors. And the brain always strives to maintain homeostasis, a balance, so we can all function. Now, I want to elaborate on this. My point to you today is to have sensitivity in advising our students who may have lost that balance due to a concussion. So, as you'll see, there's been a long history of thinking a concussion, no big deal. We now know better. We now know more. So what exactly is a concussion? Again, the old stereotype, as I was saying, it's a ding, you're seeing stars. You're playing football. So you saw stars, back on the field. That was the thinking for a very long time. However, now the U.S. Department of Health and Human Services, Centers for Disease Control and Prevention, acknowledges a concussion is indeed a brain injury. It is commonly called a mild traumatic brain injury. So if you see in the literature MTBI, mild brain injury is also concussion. I'm going to talk more about this, but we have stretching of neurons going on. Again, the brain slams against the skull. It alters the overall balance of functioning, stretching and straining of brain tissue. This also leads to reduced cerebral energy. So what we now know is, and even if you don't lose consciousness, you can have a concussion. There's a lot going on, and there's a recent article just published in the Journal of Head Trauma Rehabilitation, I think, that says it best. And this is why concussion was ignored for so long. You know, the structure's okay, the MRI looks good, you're fine. Listen to this quote: "The changes in the brain associated with mild traumatic brain injury are believed to affect the neurochemical software more so than the brain's structural hardware." So please be mindful. If one of your students reports they've had a concussion, they may have clear findings on brain imaging studies because we're looking at the software. You may have heard the term diffuse axonal injury. The neurons, the axons have been torn apart. You don't see that on an MRI. As great as MRI is, PET, SPECT, EEG, it can easily be missed. In fact, and this is a beautiful neuron, you can see. It is beautiful. Neurons are amazing. We need them. Only a neuropsychologist is in love with neurons. But it really is a great picture. And if you'll see where the axon is, oops, I didn't mean to do that. The axon up at the top, that's what's often torn, diffuse axonal injury. Leah right now is going to come up and read some statistics about brain injury.
Hello. Some statistics. A traumatic brain injury, TBI, which is a bump or blow to the head, accounts for about 30% of all injury deaths in the United States. However, not all head injuries results in TBIs. TBIs can range in the severity from mild, the most common, to severe. As previously noted, mild TBI is commonly known as a concussion. Defining a concussion as a mild TBI has increased our understanding of the recovery process and has facilitated programs to support awareness and prevention of concussions. However,
Love is now going to follow up with some statistics.
In 2009, about 248,418 children, which were the ages of 19 or younger, were treated at emergency departments for sports-related TBI. Between the years 2001 and 2009, the amount of children diagnosed with concussion or TBI due from a sports or recreation injury rose 57%.
Thank you. Great job. Our future. And now, I will ask my other students helping today to hand out the two handouts we have. One is Heads Up Preventing Concussion, and the other is Recovering. So my students will be handing these out as I begin to review this with you. What is so challenging about a concussion is you have, I call it the devastating triad. It really is devastating. Cognitive, physical, and emotional functioning is affected. I acknowledge if you break your arm and you are limited, you may have emotional distress, correct? If it's happened to any of you, you will be frustrated. The difference is when it's the brain, it's more innate, it's within. It's not an emotional response. Your emotions are affected. Your thinking is affected. So if you all have the handout right now, Heads Up Preventing Concussion, on the back are signs and symptoms. And I ask you to please keep this in your office. If you ever have a student who reports they've had a concussion, you can review and remind yourself what they may be going through. And I really like this handout because it is from the CDC. It's valid, it's reliable, it's trustworthy. I always remind my students, be careful of Googling. There's a lot of fluff and stuff. I don't want fluff and stuff in your papers. So if we look at signs and symptoms, starting to the left, difficulty thinking clearly, feeling slowed down, concentrating, remembering. Think about a student in a classroom having these experiences. Then to the right, more physical, headache, nausea or vomiting, clumsiness, balance problems, dizziness. Vision can be affected. Sensitivity to light and noise. Do classrooms get noisy? Do the hallways of Stockton University get noisy? Absolutely. Just feeling tired all the time, numbness or tingling. More emotional, irritability, sadness, nervousness, anxiety. Sleeping more often than usual or sleeping less, trouble falling asleep, drowsiness. Again, big pause button. Let's stop here. This is a lot, and every single person who has a concussion will have a unique presentation of symptoms. I can't tell you after a concussion exactly how someone will present. I can't tell you how long it will take them individually to get better, but our research tells us in weeks and coming months, we should see improvement. There is wonderful research out there emerging. And sometimes the research says give it 6 months, sometimes a year. It's very individual. So please remember that. And this is where the medical team has to work with the education team, as you will see. So what happens when a student has a concussion? Well, hopefully they're going to have a medical assessment. And it's going to be an interdisciplinary treatment team. And I'm thrilled to see some folks here from health sciences who can back me up. It does take a village. I'm coining Hillary Clinton, right? Her book. It takes an interdisciplinary treatment team to help this person. May include physicians, hopefully it does first and foremost, primary care, a neurologist who specializes in the brain, physiatrist. Many people have never heard of a physiatrist. They are physicians who specialize in physical medicine and rehabilitation. So if you were at Bacharach Institute for Rehabilitation or Health South, you would have a physiatrist who plans your care for inpatient or outpatient rehabilitation. A psychiatrist may be on board. Clinical psychologists, neuropsychologists to do testing. More and more, but not always, we are seeing folks who've had a concussion have a physical therapist, occupational therapist, speech therapist, social worker. Now, my favorite part, ideally in the perfect world that I fantasize about, every single person on this planet who has a concussion would have a comprehensive neuropsychological assessment. But this may not be covered by health insurance and may be too costly for some students and their families. It can be a few $1,000s to have a true comprehensive neuropsych. So many students may be getting a brief eval. Things may be missed. Just please note that it is important to ask the student, what medical care have you received? Now, it's up to them, as we'll talk about, to share that with you. But it would be great if they could have all this. You may have heard of this program, Impact, which we have at Stockton University. It is a model for our student athletes where they have preseason baseline testing. If a concussion is suspected, they have post-injury testing and treatment. And then it is determined if the athlete is ready for non-contact activity and is it safe to return to play. Not everyone has this in place, but it is important if they have it. Now, HIPAA, I know many of you are probably familiar with this. It's the Health Insurance Portability and Accountability Act of 1996. A student has to sign a release for you to see their medical records. Now, can they obtain a copy, let's say, of their neuropsych eval verifying a concussion? Can they get a copy themselves and then do what they want with it? Yeah, they can. You may not understand it all. I work with neuropsychologists who write eloquently and in a fashion that is understandable to all, but some speak medical jargon. But please know, the student does have the right to restrict your access, but what I'm finding happening at Stockton, which is positive, most students know now to bring their medical information to Learning Access program and get services through Learning Access in the counseling center. That's the perfect world, but I'm seeing it happen more and more. And of course, parental involvement will vary. As you all know, faculty, sometimes parents show up on academic advising day. They just pop in. Rick is nodding. Have you had that? I've never had that, but I hear it can happen. You may have parents come in who are all about, this is what my son or daughter needs. Again, you may have some, though, who are surprisingly unsupportive of the recommendations that the medical team has, or again, on the flip, overly cautious. I've seen parents disagree. I've had students tell me, you know, I had a concussion and my mom is like, get back to the game, get back to academics. We're paying a fortune for Stockton. And dad is, you know, on the other side, take a break. So there can be a disconnect. There can also be a disconnect between the healthcare system and the educational system. And I have not seen this as much. Right now, my practice, I pretty much work with older adults with dementia. My husband, who's a neuropsychologist, encounters this a lot. The situation in which it may be hard for educators to understand, again, a neuropsych report or what the physician is saying. Just open your mind and listen. You're now well educated and informed about concussion. Have an open mind. Trust the expertise. I think that's the best I can say. As the healthcare professional needs to trust you, that you're sensing the student really does need to take the semester off. And it is a challenging call to make, a very tough call. I think this handout you should all have. Recovery, you handed that one out as well? Recovery from concussion. Again, hold on to this, but please, please know. This is geared more toward children and teens, but it still is relevant for university students. This is a very general overview. We hope, again, that every student has a personalized plan by their health practitioners. The issue for us as advisors and instructors in the classroom, if the student comes back, is really making sure there's compliance, especially if there are specific issues, lack of social support. So this is where it should all start to come together. First, remember, for most students, this is the first time they're needing assistance. It may be frightening and overwhelming. You may have a student in front of you you're advising. I'm an A+++ student. I can't take a break. Yes, I have headaches, but I can't stop. Please, again, hopefully you have the healthcare information in front of you. Make sure they're going to the counseling center to deal with feeling overwhelmed and scared. Students, many of my students have opened up in my clinical neuropsych class about how scary it is to have a concussion. This bizarre feeling, just not being right. And you're trying to concentrate in a classroom. Choose your classes for next semester. It can be very overwhelming. Let them talk. Again, ultimately they may need the counseling center, but please give them a neutral, safe environment to talk about what's happened to them. It's very overwhelming. However, some students may have a past history of learning disability, attention deficit disorder, prior concussion. Again, they still may feel certainly overwhelmed, but there's a different context now. They may have a history with learning access programs, so they feel more comfortable going, but they're scared again. So you've got to refer. I'm going to be talking more in weeks to come with Bob Ross over in the Counseling Center and Learning Access, because he would also like me to work more with his staff about how to best manage concussion. But we have great services here in Counseling Center and Learning Access. And my students know the first day of class, it's in the syllabus. If you need help, the door is open. And advising should focus on reinforcing compliance with the recovery recommendations. Inform yourself, again, about what your student has been told. You can have a powerful effect on the recovery. Realistic expectations. Again, that may mean something more we'll talk about, withdrawing from a class. We all hate to disappoint students, and we have students here. Students, we don't want to disappoint you, but sometimes we have to be assertive and say, you know, with that GPA, you may want to not apply to grad school just yet. We need to be honest with you. We want you to succeed in life. So to the advisors here, the faculty, it can be some tough love. So what are issues? There's a lot of literature on the kiddies and the teens in high school, but what about higher ed, college, university level? Scheduling may need to change, increased rest periods. Maybe after a concussion, the student can return to class in a couple weeks, but the schedule they have is back to back. You as an advisor may be helping the student work out to instructors about redesigning the schedule. So there are rest breaks, or maybe one class needs to be dropped. Again, it's hard for me to be specific. Every person who has a concussion is unique. But these are pretty typical themes. May need to withdraw from the current semester or classes. Some of you have talked to me about interesting situations where the student decides, I'm going to withdraw from every class except yours, professor, because I know you and I'm going to make it. And they can't make it. They're nauseous in the classroom. Just be open-minded and maybe realize that may or may not work. Again, time of classes may be altered, related to scheduling. I mean, Scheduling can mean work schedule and academic. Here I mean more the academic classroom times. But again, there may be intense pressure to keep up. Remind your student alcohol use, illicit drug use is always bad, but can certainly exacerbate symptoms. Living arrangements. Some of our students may need to get out of where they are because it's not low stimulation. I have encountered this with many of my students, where after a concussion, they need to go home for a while or to a friend who lives off campus where it's quieter. There has to be excellent communication with instructors. Online hybrid, see my little caution sign? I have an opinion about this as a neuropsychologist and a faculty member. Proceed with extreme caution. My experience is any online or hybrid course requires an extremely high level of initiation and executive control. Students, would you agree if you've done online, you have to be very self-motivated? One of the biggest issues after a concussion is you may not be as self-motivated. Again, headaches, tired, exhausted. You may be having problems with balance and coordination, with dizziness. The last thing you want to do at the end of the day is log on to Blackboard. I don't think it's a good idea. Just proceed with caution, really have a good conversation with the student. And of course, enlist as much support as possible, as we've talked about. When I used to teach health psychology, every student learned the first wealth is health. This is a quote by poet, philosopher Ralph Waldo Emerson. Be a role model. If they are feeling pushed and trying to do too much, it's not worth it. Years ago, 2 students here taught me the value of telling little tidbits of my story. I feel we live in a TMI society, too much information. But when I told a couple of my students, Kate and Jamie, years ago, how I struggled doing this and that in grad school, it was as though I opened a new world to them. They admitted to me they thought my academic career was easy. Well, you just got into grad school and everything fell into place. Oh no, not when I was being yelled at in grad school by my supervisor, who nearly made me cry, when I was denied my most hopeful, wonderful postdoctoral fellowship. It all worked out in the end. I wound up where I had to be, but we've had disappointments. I was delayed getting my license as a psychologist by a couple years. I was caregiving for a family member. My students know my thing well. The earth didn't open and suck me in. I'm alive. It was okay that I needed more time. This is the struggle of many of our students with a concussion, but I'm going to lose a semester. We must advise well. If the physicians and the medical team are saying you need a break, the first wealth is health. Maybe you have a little lighthearted story you can share with them to inspire them. Really, Kate and Jamie just got their master's degrees. They're working in the field of psychology. They taught me so much. Because just that little bit of information, I don't know, is this true, students? You look at us like robots, like everything's easy? We never had the pain of applying to grad school. We never shed tears. And again, I've already mentioned this, recovery from concussion varies several weeks to months. However, I must mention, malingering is the intentional feigning or exaggerating of symptoms for secondary gain. You must be alert to this. Can we prove it? No. But a neuropsych eval may indicate a student is exaggerating symptoms. We are seeing more and more of this in the clinical world. We are in tough economic times. If you've had a concussion and you pursue litigation, there are attorneys who will coach you how to perform on a neuropsych test to fake an injury. This is real. We're seeing more of it. The stats are exploding. All I can tell you is to always, what do they say, little kids, have eyes behind the back of your head. If you're getting a feeling it doesn't make sense and the student's not getting better, really, again, that's up to the medical team, but you may want to ask them, why aren't you getting better? One of my colleagues had a situation last semester that was fascinating. Student had a concussion, got all the supports in place, never used the supports of Stockton. Missing class. 2 months later, I want to pass. No can do. I don't like that. That's a red flag to me. You had your chance. Why didn't you? Well, it was fishy. So just be alert to this. I hate to be negative, but the intentional faking of brain injury is so on the rise. Again, my husband does a lot of this work, and it's the client who comes in. They were able to find the office from an hour away. They drove themselves there. You ask them to draw a clock. Oh, I just can't. Oh, I can't deal with this. Let me lay down. I don't know how to draw a clock. And they'll have a panic attack that doesn't seem quite real. Anthony's nodding. Yeah, you see this stuff. Yeah. We'll discuss at the end. We're almost done. To wrap things up, there is something now that Dr. White and Doris have researched very well, gave a talk on. Chronic traumatic encephalopathy. This results from repetitive trauma to the brain, and there are young people as young as 17 who've been diagnosed with it. Am I right? Or even younger? I think that was the youngest case. What we now know is when you've had repetitive, multiple concussions, it's an issue. And you may have heard about this, the movie Concussion with Will Smith. What started our understanding of chronic traumatic encephalopathy is well documented in this PBS special. And I'm going to show you a snippet of the first football player who tragically died at the age of 50, Mike Webster. He died in 1990 at the age of 50. He played for a couple different teams, lastly the Pittsburgh Steelers. It is sad, tragic, yet fascinating for me as a neuropsychologist to see that it's really only on autopsy you can see this. And again, research is now moving toward Pop Warner. There was a recent study last year I shared with my neuropsych class. They are starting to study Pop Warner football players, and over one season, the brains of these little children on fMRI, they're different. Because there's concussion, and there's something called subconcussive hits. Has anyone heard of this? You don't see the concussion happen. It's not like the player bangs his head and falls down. It's just throughout the game, movement of the brain. So I'm going to ask Zach to come forward before we watch a video clip. For the record, I am a Dallas Cowboys fan. This belongs to my son. Go Cowboys next year, Dak Prescott. Here's the issue. So all of our football players wear these wonderful helmets. They're improving. But again, we put the brain in there. The brain is surrounded by cerebral spinal fluid, the skull. The subconcussive hits happen. It's going to move. Did you see in the Super Bowl helmets fly off? Yeah. So, we put our brain in here, but it's limited in what it's going to prevent. Makes sense? Thank you. Again, do I have any Dallas Cowboys fans? Briefly, I want to show you a clip from League of Denial, the NFL's concussion crisis. My students watch it in neuropsych. It may forever change how you watch football. I am a diehard football fan. I was taken to a Rutgers football game when I was 3 years old, and I fell in love. My dad was one of those guys who believed in college football because they don't get paid. He said, I feel more for the quarterback playing for the spirit of Rutgers than the guy making a few million. So very briefly, I'm just going to show you a little bit about Mike Webster. You're actually going to see him speak and how he was impaired cognitively from chronic traumatic encephalopathy. And I'll start wrapping things up.
In 1991, Mike Webster left football. Soon, he and his family would come to believe those hits to the head had taken a devastating toll.
Mike wasn't Mike. He was angrier, quicker than before, and didn't have the patience to have, the kids on his lap or take a walk with the kids. Like, he didn't have that stamina physically.
Over the years, he became increasingly confused.
He would forget, which way the grocery store was, which way it was to go home. He broke down in tears in front of me a couple times because he couldn't get his thoughts together and he couldn't keep them in order.
At home, there were bouts of rage.
He took a knife and slashed all his football pictures. They were all destroyed and gone and broken glass, and they were all down, and it wasn't Mike.
They'd been college sweethearts, but 27 years and 4 children later, Mike and Pam Webster's marriage ended.
We didn't understand what was happening. You're just trying to get by in this storm. I mean, your money's gone, your pride's gone, our bills are all overdue, our house is getting foreclosed, all the security is gone. All those parameters are removed, so everything's crumbling.
Once one of Pittsburgh's greatest football heroes, Webster began living out of a pickup truck.
I'd come outside sometimes and just see him, sitting in the truck, and it would be freezing, and he'd just be sitting there just looking miserable. He said, the worst thing is I'm actually getting to the point where sometimes, or if I don't have my medicine, he said, I'm cold and I don't realize that I can fix it by putting a jacket on.
Webster was often unable to sleep.
He had a lot of pain, and he hasn't slept for days. So he asked me, says, "Sonny, can you tase me?" I'm like, "What does that mean?" So he pulls out this stun gun and goes, zzz, bzz. I'm like, "Mike, that's not healthy." He said, "But I haven't slept nothing." He said, "All you got to do is tease me right here." And I'm like, "Okay, he's my hero. I'm going to do whatever he tells me." So I teased him, and he goes to sleep. I'm like, wow.
A true champion who wound up homeless, depressed.
The story of Webster's decline was revealed on ESPN and then the local
He was
newspapers.
arrested for forging 19 prescriptions for Ritalin, which he used to combat the erratic behavior caused by his damage.
I think he was embarrassed. He was a leader on the team, and he was Mike Webster, and then to be down to a place of poverty, a place where, your brain can't function to finish a sentence, without some help from Ritalin or whatever you need to function for a short period of time.
For Iron Mike, TV interviews became impossible.
No, I'm talking about... No, I'm just trying to find... Yeah, well, trauma, everybody went through trauma as a kid. I'm not saying I was different than that. I'm just saying... the things we do to one another, okay? Hell, I don't know what I'm saying. I'm just tired and confused right now. That's why I say I can't really, I can't say it the way I want to say it. I could say I could answer this real easy at other times, but right now I'm just tired.
Maybe the saddest I ever heard him say was when someone saw my dad and, "Aren't you Mike Webster?" And he said, "I used to be." I think that was really how I felt, because he really was. He wasn't the same person. It was like, a picture of him that was just shattered into a million pieces.
And just to wrap up, I want to thank all of my students and colleagues who continue to enhance our knowledge. More and more I find students and faculty talking to me about concussion. The more we talk about it, acknowledge it, we can advise better. So thank you very much.
And thank you, Christine, for such a great presentation, very informative. Let's give her a hand.